Kidney disease, a condition that silently steals away health and energy over years. Before dialysis becomes inevitable, there is a window of hope. In this session, we'll walk together through the steps of managing CKD before maintenance hemodialysis, how to slow its progression, prepare patients, and give them a better quality of life. Our objectives are clear. First, to understand how CKD progresses and when dialysis is truly indicated. Second, to explore the strategies that can help us manage patients effectively before dialysis. Third, to highlight the importance of patient preparation and education. And finally, to appreciate the teamwork doctors, nurses, dietitians, and families all working together in pre-dialysis care. CKD is not just about weak kidneys, it's a spectrum of structural and functional kidney abnormalities. By definition, it means either a GFR below 60 for more than 3 months, or the presence of persistent markers like albumin in urine, abnormal imaging, or genetic diseases. CKD is a long journey, not a single moment, and that's what makes early recognition so critical. CKD is progressive. The decline in kidney function isn't sudden, it's like a slow erosion. The risk depends on where the patient starts their baseline GFR, how fast it's falling, and how much albuminuria is present. Left unchecked, CKD quietly advances to stage 5 kidney failure. But if caught early, the speed of decline can be slowed, giving patients more healthy years. The roots of CKD are many. Non-communicable diseases like diabetes, hypertension, and obesity are among the strongest drivers. Infections, HIV, hepatitis, even tuberculosis also play a role. Add to that age, genetics, lifestyle habits like smoking, and a history of prior kidney injury. Each factor may seem small, but together they form a dangerous web leading to CKD. Genes too leave their mark. Monogenic disorders like polycystic kidney disease or Alport syndrome are well known. In some populations, such as African ancestry, APOL1 gene variants increase vulnerability to CKD. Beyond these, research continues to uncover multiple genetic variants. Understanding this helps us identify high-risk individuals earlier, sometimes before disease even begins. The KDIGO 2024 guidelines remind us that CKD staging is based on both GFR and albuminuria. Stage the 1st of May look deceptively normal, kidneys appear to filter well, but damage is already present. Stage 2 is mild decline, Stage 3 moderate, Stage 4 severe, and Stage 5 kidney failure. Remember, a number on paper is more than a statistic. It represents the body's struggle to filter and survive. Early stages often show no symptoms. As function declines, anemia, fatigue, poor appetite, bone disease, and hypertension begin to appear. By stage 5, uremia sets in with electrolyte imbalance, malnutrition, swelling, and neurological changes. For patients, this journey is exhausting, but as clinicians, our role is to catch the disease before it steals away quality of life. To track CKD, investigations are our compass. eGFR calculated from serum creatinine or cystatin C gives us a picture of filtration. The urine albumin to creatinine ratio signals ongoing damage. Add to this serum electrolytes, calcium, phosphate, vitamin D, and imaging of the kidneys. Newer tools like the kidney failure risk equation even help us predict the future. Each test is a piece of a larger puzzle. Before we talk when to start dialysis, let's predict who is likely to reach kidney failure soon. The kidney failure risk equation uses age, sex, eGFR, and albuminuria to estimate 2- and 5-year risk. Sharing this number with patients turns uncertainty into a plan, monitoring, diet, access planning, even preemptive transplant at the right time. Why is early recognition of CKD so important? Because CKD is not just about kidneys. It multiplies the risk of heart disease, infections, drug toxicities, and eventually, end-stage renal failure. Every step we take in early management can slow down progression, reduce complications, and most importantly, give our patients not just more years, but healthier, fuller years. In CKD, the body loses its fine balance. Sodium and water retention lead to swelling and high blood pressure. Potassium, usually well controlled, can suddenly rise to dangerous levels in later stages. And when the kidneys can no longer excrete acids, metabolic acidosis sets in, slowly breaking down muscles and bones. These aren't just lab values. They are daily struggles for patients trying to breathe, move, and live. Why does metabolic acidosis happen in CKD? Simply put, the kidneys fail to excrete hydrogen ions and can't regenerate enough bicarbonate. Acid builds up silently. The result? Protein catabolism, faster CKD progression, and muscle wasting. It's like a slow burn within the body, one that quietly pushes the disease forward. Thankfully, we have strategies. Salt restriction, loop diuretics, and careful water management help maintain balance. Hyperkalemia. One of the deadliest complications can often be prevented with diet, diuretics, or potassium binders. When these measures fail, dialysis becomes the final option. Each intervention buys precious time, holding back the tide of kidney failure. As kidneys fail, bones suffer. Phosphate builds up, vitamin D activation drops, calcium falls, and parathyroid hormone rises. The outcome? Fragile bones, fractures, deformities, and sometimes even painful calcification in soft tissues. It's heartbreaking when young patients complain of severe bone pain, a direct consequence of unchecked mineral imbalance in CKD. Management is about prevention and balance. Diets low in phosphate, medications like phosphate binders, vitamin D therapy, and calcimimetics can help. But here lies a challenge. Too much suppression of parathyroid hormone leads to weak, adynamic bones. Too little suppression, and bone destruction continues. It's a delicate dance, one that requires vigilance and compassion. The heart and kidneys share a cruel connection. In CKD, cardiovascular disease is the leading cause of death. Hypertension, anemia, vascular calcification, and metabolic stress accelerate heart failure and coronary disease. For many CKD patients, it is not the kidney failure itself that claims life, but the silent, relentless strain on the heart. Patients may develop left ventricular hypertrophy, heart failure, or even pericarditis. Sometimes troponins are chronically high, confusing clinicians about heart attacks. Even a simple fistula for dialysis can overload the heart. Each heartbeat tells the story of kidneys failing to maintain balance. Managing the heart in CKD is just as vital as managing the kidneys themselves. Control of blood pressure is central with a target below 130/80ths, especially in patients with diabetes or proteinuria. ACE inhibitors, ARBs, and even newer drugs like SGLT2 inhibitors not only protect the kidneys but also safeguard the heart. Treating cholesterol, diabetes, anemia, and bone mineral disease together reduces the risk. Sometimes only dialysis or transplant can lift the burden off the heart. Think of BP control as kidney CPR. Aim for less than 130/80 mm of mercury, especially with diabetes or proteinuria. Use ACE inhibitor or ARB first line. Monitor creatinine and potassium. Add SGLT2 inhibitors for cardiorenal protection. If potassium creeps up, use kaliuretic diuretics or binders like Pataromer or SZC to stay on life-saving meds. When uremia inflames the pericardium, that's not a watch-and-wait moment. Uremic pericarditis is an absolute indication for dialysis. Start or intensify dialysis without heparin, and if there's tamponade or recurrent effusion, drain it. Always check for other causes too: infection, malignancy, autoimmune disease, Michigan, even minoxidil. Anemia is almost universal in advanced CKD. It begins with reduced erythropoietin production and worsens with nutritional deficiencies, bleeding, and inflammation. Patients feel exhausted, breathless, unable to focus. Their hearts pump harder, their immunity drops, and their quality of life suffers deeply. Correcting anemia is more than raising hemoglobin, it's restoring energy, hope, and dignity. The arrival of erythropoiesis-stimulating agents changed CKD care forever. They reduce the need for risky blood transfusions and give patients strength to carry on. But treatment isn't without risk: strokes, thrombosis, and even faster kidney decline if overused. That's why balance is crucial. Ensuring iron, vitamin B12, and folate are adequate before ESAs makes therapy safer and more effective. Erythropoiesis-stimulating agents are a blessing, but like every medicine, they carry risks. Studies show no proven cardiovascular benefit, and in some cases, they even increase the risk of stroke, blood clots, and faster kidney decline. That's why we aim not for normal hemoglobin, but for safe levels around 10 to 11.5 gram per dl. In CKD, safety is always about finding balance, not perfection. Sometimes, even with ESAs, hemoglobin won't rise. Why? Inflammation, ongoing blood loss, severe hyperparathyroidism, or infection may blunt the effect. It can be frustrating for patients and doctors alike, but this resistance is a reminder treating anemia is not just about one drug, but about addressing the entire body's needs. Iron, folate, and vitamin B12. These are the hidden keys to effective anemia management. Without them, ESA therapy simply won't work. Adequate nutrition is not just a prescription, it is the foundation of healing. For many patients, correcting these deficiencies brings back energy and vitality faster than they imagined. A new dawn in anemia management is here: hypoxia-inducible factor stabilizers. These drugs boost natural EPO production and improve iron absorption. Early results look promising, but we must remain cautious. Long-term safety, especially for the heart and cancer risks, is still under study. Science gives us hope, but wisdom demands patience. Diet is medicine for CKD. Restricting protein reduces nitrogenous waste, lowering the strain on kidneys. Sodium, potassium, phosphorus, and fluid must all be carefully balanced. Imagine the discipline patients need: avoiding favorite foods, limiting water, saying no to fruits like bananas or coconuts. As doctors, we must not just prescribe diets, but support and encourage patients through these sacrifices. CKD patients live on a knife's edge. They bleed easily, yet also face risks of clotting. A simple bruise may become prolonged bleeding. A minor surgery may mean unexpected complications. And yet, paradoxically, clotting risks like thrombosis also increase. This duality makes hemostasis in CKD one of the most complex challenges in clinical medicine. We do have solutions, though temporary. Desmopressin, cryoprecipitate, or estrogen infusions can correct bleeding tendencies for short periods. Optimizing dialysis itself often improves platelet function. But during emergencies like surgery or severe bleeding, quick correction saves lives. Each intervention is a tightrope walk between stopping bleeding and avoiding clots. Blood thinners in CKD are a double-edged sword. Warfarin may control atrial fibrillation but increases the risk of calciphylaxis, a devastating complication. Low molecular weight heparins need strict monitoring, while newer agents are often unsafe. UFH is safer in hospital with PTT monitoring. Among NOACs, apixaban is relatively safer, but still dose adjust with caution. Individualize, reassess, and document the plan. Here, clinical judgment is more important than any textbook rule. The brain, nerves, and muscles all feel the weight of CKD. Patients may suffer from memory loss, poor concentration, cramps, restless legs, or even seizures. Asterixis. The flapping tremor becomes a clinical hallmark of advanced disease. These symptoms are not just medical signs. They represent nights of sleeplessness, constant discomfort, and an invisible suffering that dialysis only partly relieves. The gut, too, bears the brunt of CKD. A metallic taste in the mouth, foul uremic breath, constant nausea, ulcers, constipation, and gradual weight loss. These problems rob patients of the simple joy of eating. Many slip into protein-energy malnutrition, a silent killer in CKD. When malnutrition sets in, it's often the final call for starting dialysis. Numbers guide us, symptoms decide us. Start renal replacement when there's refractory hyperkalemia, fluid overload, acidosis, uremic complications, and don't forget the quieter triggers: progressive peripheral neuropathy with no other cause, or severe protein-energy malnutrition despite best care. Starting on time prevents irreversible harm. CKD changes the way the body handles hormones. Insulin lasts longer in the blood, making diabetes management unpredictable. Drugs like metformin or sulfonylureas become dangerous as GFR falls. Reproductive hormones also drop. Women face irregular cycles, infertility, and high-risk pregnancies, while men struggle with low testosterone and sexual dysfunction. Even children face delayed puberty. Beyond numbers and lab reports, these are deeply personal battles that affect identity, relationships, and quality of life. The skin speaks when kidneys fail. Severe itching uremic pruritus becomes relentless, robbing patients of sleep. Pigmentation changes leave the skin darker, drier, fragile. In rare cases, nephrogenic fibrosing dermopathy causes painful skin tightening. Even something as basic as a moisturizer becomes a form of relief. These symptoms remind us CKD doesn't just damage inside, it changes how patients look, feel, and interact with the world. Imaging saves lives, but gadolinium can trigger nephrogenic fibrosing dermopathy in advanced CKD. If GFR is less than 30, avoid gadolinium unless essential. Newer agents are safer, and if you must use it, arrange urgent dialysis right after. The goal is clarity in imaging without collateral harm. Knowledge is power, especially in CKD. Patients must learn early about dialysis, its options, and its challenges. They should recognize symptoms of uremia before it's too late. Education transforms fear into understanding, and confusion into decision-making. When patients and families are empowered with knowledge, they don't just follow treatment, they own it. Depression and anxiety are silent companions of CKD. The thought of lifelong dialysis or transplant is overwhelming. Here, family support, counseling, and peer groups make all the difference. Sometimes just listening is therapy. Sometimes reassurance is as powerful as medicine. Healing the mind is as important as healing the kidneys. Infections can devastate a CKD patient, and HD units amplify that risk. Vaccines against hepatitis B, influenza, and pneumococcus become life-saving shields. They may seem like small injections, but for a patient who will soon face dialysis, they are layers of protection against deadly infections. Prevention here truly is better than cure. Vaccinate early, hepatitis B, ideally before starting HD, influenza annually, and pneumococcal with PCV13 followed by PPSV23. These are small shots that prevent big setbacks. In CKD, every prescription and every pill matter. Some common drugs like NSAIDs or certain antibiotics can worsen kidney damage. Doses of renally cleared drugs need careful adjustment. Polypharmacy often overwhelms patients. Avoid NSAIDs and unnecessary contrast. Keep the list lean, fewer pills, fewer errors, fewer admissions. A thoughtful medication review can prevent toxicity, lighten pill burden, and give patients both safety and simplicity in their care. For patients approaching dialysis, vascular access is lifeline planning. An arteriovenous fistula, placed well in advance, is the gold standard. Catheters may be quick but invite infection. Planning access early is an act of foresight. It means fewer emergencies, fewer hospitalizations, and more dignity for the patient when dialysis begins. An AV fistula is a lifeline, not a last-minute fix. Plan it at least 6 months before expected dialysis, with vein mapping and time for maturation. Late referrals force catheters, and catheters mean infections and hospitalizations. Early planning is not just a medical decision, it's a gift of safety to the patient's future. A kidney transplant is not just treatment, it's renewal of life. Early referral for transplant evaluation ensures patients don't miss the window. Living donor options often give the best outcomes, and when done before dialysis begins, preemptive transplant spares patients from years of exhausting hemodialysis sessions. For many, this is the ultimate hope. Not every patient will choose dialysis or transplant. For some, especially the elderly or frail, conservative management may be the kinder path. Advanced care planning ensures their wishes are respected. These are difficult emotional conversations, but they bring clarity, dignity, and peace. Medicine isn't only about prolonging life, it's about respecting how patients wish to live it. When kidney function fails, dialysis becomes the bridge to life. Hemodialysis performed in centers, usually thrice a week, offers close monitoring, but ties patients to machines. Peritoneal dialysis, done at home, gives freedom and flexibility but requires discipline and training. Each choice carries hope, fear, and sacrifice. Our role is to guide patients toward the option that fits their life, not just their disease. Home therapies, home hemodialysis, CAPD, and automated peritoneal dialysis empower patients to take charge. They offer more flexibility, better blood pressure control, and often a better quality of life. But they also demand commitment and support from families. It's medicine moving from hospital walls into the heart of the patient's home. The best outcomes in CKD come when a transplant is done before dialysis ever begins. Preemptive transplantation avoids the complications of long-term dialysis, offering patients a fresh start. It requires early referral, early planning, and sometimes extraordinary courage from living donors. But for those who get it, it feels like a second life. Not all patients want dialysis or transplant. For some, the focus shifts to comfort, dignity, and symptom relief. Conservative management means treating fatigue, nausea, itching, and other symptoms without aggressive interventions. It's not about giving up, but about choosing a different kind of care. One that honors life in its final chapters. The nephrologist is more than a specialist. They are the captain of the CKD journey. From slowing disease progression, to adjusting medications, to guiding dialysis and transplant decisions, the nephrologist brings science, compassion, and foresight together. For patients, this trust often becomes a lifeline. CKD care is not the nephrologist's burden alone. Primary care physicians play a vital role controlling diabetes, hypertension, and cardiovascular disease, spotting early kidney decline, and ensuring continuity of care. Collaboration ensures patients don't fall through the cracks. It transforms care from fragmented to holistic. Nurses and dietitians are the unsung heroes of CKD management. Nurses teach, monitor vascular access, and provide comfort during dialysis. Dietitians tailor renal diets, balancing nutrients while respecting culture and affordability. Their constant presence ensures patients are not just treated but cared for. CKD is as much a financial and emotional burden as it is medical. Social workers and counselors help families navigate insurance, government schemes, and dialysis logistics. They address transportation, caregiving, and the unspoken emotional toll. By lifting these burdens, they give families the strength to keep going. In CKD, food itself becomes treatment. Sodium must be restricted to control blood pressure and swelling. Potassium-rich foods like bananas and coconut water must be limited to prevent sudden heart rhythm changes. Phosphorus-heavy foods like cheese and processed meat weaken bones and blood vessels. Even protein intake must be carefully adjusted. Make diet doable. Sodium, around 400 mg per meal, 150 mg per snack. Potassium, limit high-K foods, bananas, coconut water, ragi. For phosphorus, cut back cheese, canned fish, processed meats. Protein, usually 0.6 to 0.8 gram per kilogram per day in non-dialysis CKD. Personalize with your dietitian. For patients, every meal becomes a conscious act of self-care. To summarize, CKD is a long journey, but with early recognition, multidisciplinary care, patient education, and emotional support, we can slow its progression and give patients a fuller life. Management before dialysis is not just about numbers, but about preserving dignity, hope, and strength. As George W. Thorne once said, "The goal of medicine is not just to add years to life, but to add life to years." Thank you.